Well, good afternoon, ladies and gentlemen. Thank you very much, Professor, for your help. Now, my name is He Jialiu from Southeast University School of Public Health in Nanjing, China. I'm proud to have the opportunity to attend this conference on Singapore. Today, I'm honored to present on this topic, association between kidney function and mortality in type 2 diabetes mellitus patients, a 10-year prospective cohort study in China. Well, I will show my presentation around these following topics. Firstly, let's talk about the background of this study. As we all know, the diabetes is one of the most common chronic diseases around the world. And the type 2 diabetes mellitus, the abbreviation is T2DM. The T2DM is the most prevalent type in diabetes patients. And in 2021, as shown in figure 1, the prevalent cases with type 2 diabetes had exceeded 500 million and resulting in a severe disease burden for people. And China has the highest number of type 2 diabetes mellitus patients around the world. And showed in figure 2, the prevalence of T2DM in China is still increasing. So, however, the major cause for the burden for T2DM is not only for itself, but also comes from its complications. Long-term hyperglycemia status can damage the blood vessels in brains, heart, and even kidneys, leading to impaired kidney function. For example, the diabetic kidney disease and the chronic kidney disease are considered the most common types of kidney diseases, and the impaired kidney function is caused by diabetes. And in clinical practice, the estimated glomerular filtration rate, eGFR, and serum urea and serum uric acid are commonly used indexes for kidney function testing. In details, the eGFR represents the glomerular filtration capacity, while the serum urea and the uric acid indicates the metabolic function for urinary system. And on the other hand, the figure 4 shows the different causes of death among T2DM patients. Cardiovascular diseases is the most common causes of death in diabetes patients, and about nearly 14% of T2DM patients were died from cancers. Our previous research shows that the T2DM patients in China have an increased mortality risk of chronic respiratory diseases. So, therefore, it is important to provide the precise management and try to reduce the mortality from T2DM complications. Meanwhile, the abnormal kidney function is also associated with all-cause mortality. Previous studies have shown that the lower level of eGFR and the higher level of uric acid and urea can increase the risk of all-cause mortality. And this phenomenon has been confirmed in diabetic patients. However, the risk of different cause-specific mortality for T2DM patients are not clearly defined yet. And this phenomenon has not been validated in Chinese T2DM patients. So we want to explore the association between kidney function and the mortality risk in Chinese T2DM patients according to a prospective cohort. The figure 5 shows the overall design of the our study cohort. All participants were included in the project of comprehensive research on the prevention and control of diabetes, CRPCD. It is an ongoing prospective cohort in Jiangsu province, China. At baseline, 3 districts or counties from Suzhou City and Huai'an City were selected as the study areas. The baseline survey was conducted in 2013 to 2014, and the long-term follow-up was conducted to focus on the outcome of T2DM complications, including the mortality and the incidence. Well, a total of 20,340 T2DM patients were included at the baseline. At baseline, the participants were asked to receive a face-to-face questionnaire, physical examination, and fasting blood sample collection. The questionnaire information included the demographic characteristics, daily lifestyles, personal history, and family history for common diseases. And the participants were required to receive the physical examination and collect the information of height, weight, risk circumstance, blood pressure, and heart rate. Besides, they are required to receive the blood sample testing for lipids, glucose, liver function, and kidney function indexes. And in this study, we excluded the patients with missing information about the questionnaire, the physical examination, and the blood sample testing. So finally, a total of 19,919 patients were included in this study. Before analysis, the testing methods and the equipments for kidney function were shown in Table 1. Besides, the eGFR level was calculated by MD-RD equation according to serum creatinine and adjusted by females and Chinese. Meanwhile, the outcome of each mortality information was coded by the 10th edition of International Classification of Diseases, mainly including the all-cause mortality and different cause-specific mortality. We divided the levels of eGFR, serum urea, and serum uric acid into 5 quintiles, means Q1 to Q5, for analysis. And we used the Cox regression models to evaluate the associations between each index and mortality for T2DM patients, and calculating the hazard ratios and confidential intervals. Moreover, we also use the restricted spline, cubic spline to show the nonlinear those response relationships. And we also conducted the stratified analysis and sensitivity analysis, and used the reservoir operating characteristic curves, ROC curves, to explore the best cutoff value for each index and with the mortality. Okay, now let's move to the part of results. The baseline information of T2DM patients in this study was shown in Table 3. The mean age was 69.5 years, and the proportion of females were higher than males. Nearly 69% of patients has a behavior of oral antibiotic medication, and as the eGFR levels decreased, the proportion of baseline hypertension also increased. Look at the Table 4. During a median follow-up of 9.77 years, 4,428 patients died, and 2,024 of them were males. And we defined the lowest quintiles, of course, the Q1 of each index as a reference groups in the Cox regression models, as shown in Table 4. Compared to Q1 and adjusting for such covariables, the higher level of eGFR was significantly negative associated with all-cause mortality. Meanwhile, the positive association was found in the highest level of urea and uric acid. For the hazard ratios were 1.27 and 1.21. Subsequently, we analyzed the association of kidney function index and different cause-specific mortality. And in this table, we found that the increased eGFR level can reduce the cardiovascular mortality risk, and the positive associations were also found in the highest level of urea and uric acid. However, the negative association was found in increased urea level and cancer mortality. For the chronic respiratory disease mortality, we observed the negative associations for eGFR, uric acid, respectively. And as shown in this figure, we found a decreased trend of mortality risk with increasing eGFR level, and the dose response relationships of urea and the uric acid for the all-cause mortality risk will show the U-shaped trends. As shown in figure 8, when we stratified by age, sex, and the duration of T2DM and the level of physical activity, eGFR was also negatively associated with all-cause mortality. And as compared to the group 1, the risk of highest level of eGFR was not significant in males. And for urea and uric acid, we found the potential interactions for alcohol consumption frequency on the all-cause mortality risk. And finally, we evaluated the best cutoff values for each kidney function index by with the all-cause mortality by ROC curves. The best cutoff values for each index was 88.5 millimeters per minute per 1.73 square meters and 6.95 millimoles per liter and 324.5 micromoles per liter. And we also reported the true positive rates, false positive rates, and the areas under the curve for each index with the all-cause mortality. Well, that's the main results of this study. And for the part of discussion, we talk about the key strengths and the limitations. The key strengths of this study are the large sample of Chinese T2DM patients and the accurate information and definition of each kind of mortality, and the precise measurement for baseline kidney function index. However, several limitations also existed. Firstly, we are unable to determine the sequence between baseline kidney dysfunction and the occurrence state of diabetes, and this may be lead to some biases. And secondly, we only use the baseline testing data for kidney function, but these indexes may have a change during the long-term follow-up. And finally, we cannot ignore the impact of COVID-19 pandemic on the mortality data. So, in conclusion, in the graphical abstract, we found the abnormal kidney function indexes was associated with all-cause and cause-specific mortality in Chinese T2DM patients. And more attention should be focused on lower eGFR, higher urea, and higher uric acid to reduce different mortality. And future studies are needed to explore the mechanisms with abnormal kidney function to cause specific mortality. Well, finally, I would like to express my thanks to my teacher, Professor Wu Ming, and all of the members of my research team. Meanwhile, I want to thanks to all of the participants included in CRPCD Cohort study. Okay, that's all. Thank you for your attention. Thank you very much.